Thank you, Andreas, for the introduction. So this talk will primarily focus on the biomechanic principles of elbow instability, but I think the knowledge of these concepts is very important to treat your patients with elbow instability. And so the elbow, like the shoulder, relies on dynamic and static stabilizers. So the static stabilizer of the elbow are the capsule, the ligamentous complex, and the articular surface. The dynamic stability is provided by the muscles crossing the elbow joint. However, in contrast to the shoulder, the elbow relies much more on the static stabilizers than on the dynamic stability. And this is also pictured in this well-known diagram, which was published by Dr. Sean O'Driscoll, and he illustrated the elbow instability as the walls of a medieval castle. So you have an outer wall that is composed of the ulnar humeral articulation, the anterior bundle of the UCL, and the LUCL. And then you have the inner wall, like the second wall of defense against instability, which comprises the radiocapitular articulation, the common flexor, and extensors. So let's start with the primary stabilizers of the elbow joint. And there we would like to first focus on the ulnar humeral articulation. So in the ulnar humeral articulation, we have first the olecranon, and this is a very important restraint against axial compression loads within the elbow. On the diagram on the left, you see results which were obtained by a study by Dr. Murray, and they applied the axial load through the elbow coupled with internal and external rotation. And then they performed serial resection of the olecranon. And you can see that with each resection, the axial compression stability decreased in a linear fashion. And from this result, it is believed that you can lose up to 50% of your olecranon without losing much of your axial compression stability. And this might be important if you treat patients with irreparable olecranon fracture, comminuted fractures. You can spare up to 50% of your olecranon. On the other hand, the olecranon is also a stabilizer for varus and valgus instability. And this study on the right, which was published by Dr. King's group, they again performed serial resections of the olecranon using a computer-navigated software, and then they applied varus and valgus loads. And they could see that with each step of resection, there was again a significant decrease of varus and valgus instability. And the gross drop of stability was noted when about 75% of the olecranon were resected, and that was due to the concomitant resection of the attachment of the UCL. So in the ulnar humeral articulation, we also have the coronary process. It's a very important buttress against posterior directed forces within the elbow. And these forces occur under physiologic conditions because both the flexor and extensor muscle have a posterior directed force throughout the arc of motion. So in flexion and extension, the elbow has always a tendency to dislocate posteriorly. That's why we need this coronary process. How much of the coronary process do you effectively need? So this was tested in this study by Klaxi. So what they did is that they applied a posterior directed force through the ulna and of 100 Newton, and then they created artificial coronary fractures, type 1 to type 3, according to Regan and Murray. So type 1 just tip, type 2 more than 50%, type 3 less than 50% present. And they could see that only with a type 3 fracture, they could observe a significant posterior translation with the load applied, in flexion and extension. The coronary process through its anteromedial facet is also very important stabilizers for varus stability, and this is very important in anteromedial elbow dislocations. And again, this study looked at how much you can lose of the coronary without having a significant decrease in varus stability. And again, the number of 50% came out. Of course, you always lose a bit with each resection, but at 50%, the elbow became crossly unstable. So as a rule of thumb, we can say you can, as long as you have 50% of the coronary preserved, the elbow is more or less okay regarding stability. And in clinical practice, you can easily assess that. You just draw a line parallel to the longitudinal axis of the ulna, starting from the tip of the olecranon, and in the lateral view on the X-ray, if the cone exceeds this line, more than 50% is still present. So now let's move to the collateral ligaments, and now first the lateral side. There we have the lateral ligamentous complex that is composed of the well-known LUCL. It's very important to know the anatomy. It starts at the lateral epicondyle here and its anteromedial aspect, and then travels down to the crista supinatoris. It has an intimate connection to the annular ligament. And then we also have the RCL, the radiocollateral ligament, that is anterior to the LUCL and has a direct connection with the annular ligament. The lateral ligamentous complex is the primary restraint against posterolateral rotatory instability. And what does that mean? If you lose these ligaments here, what happens is that if you go into extension, you might observe external rotation of the olecranon away from the trochlea concomitant to a posterior translation of the radial head. And you can also see that quite well on arthroscopy if the video works. Let's see. So when you have your camera in the posterolateral compartment, you can look towards the olecranon. If you then perform a pivot shift maneuver, then you have a gross opening or rotation of the olecranon away from the trochlea, and that is a sign for a posterolateral rotatory instability. Traditionally, PLRI was ascribed to just a loss of the lateral ulnar collateral ligament, but this study from Dr. Kring's group showed that probably you have to lose both. So the lateral ulnar collateral ligament and the radial collateral ligament for posterolateral rotatory instability to occur. And what is also shown in this graph on the right is that the extensor muscles can compensate for a loss of the LUCL and RCL to some extent. So you see here they cut the lateral ligamentous complex and then they just performed a passive external rotation as shown here by these white bars, and then they activated the muscle and then the external rotation significantly decreased. And this is important to know for your diagnosis. So in an awake patient, when you still have activity of the extensor tendons, probably it's very hard to diagnose and to see the posterolateral rotatory instability, as you can do it in the so-called pivot shift test. But in an anesthetized patient like this, you can see it very, very well. So how can you obtain a posterolateral rotatory instability? Classically, it's due to a traumatic event, so a subluxation or dislocation of the elbow. If you fall on your outstretched supinated hand, you have axial load, the supination within the forearm relative to the humerus, and that can cause the lesion of the lateral ligamentous complex. But it can also occur in the context of a degenerative disease. And classically, it can occur concomitant to a tennis elbow because patients get sometimes the steroid injections. They harm the lateral ligamentous complex. And probably it's also due to the chronic overload of the lateral ligamentous complex due to the insufficiency of the extensor tendon. A varus deformity of the elbow, as shown here on the right, can also lead to a continuous stretch of the lateral ligamentous complex, and this patient actually developed a posterolateral rotatory instability due to this invarus malunited supracondylar fracture he sustained in his childhood. So now let's move to the medial side, and there we have the ulnar collateral ligament. It is also composed of three different structures. We have the anterior bundle traveling here from the anteromedial facet to the crista supinatoris, but we also have a posterior bundle and a transverse bundle. The attachment of the UCL is quite broad. It's up to 3 centimeters here on the crista supinatoris. And this is also important to know if you do ligamentous reconstruction, it starts about 3 millimeters away from the articular surface. And these studies looked at what component of the UCL is most relevant to provide valgus stability of the elbow. So again, they performed serial resections here on the UCL. First, they detached the posterior bundle, which is here marked in green. So this is the green line. And they applied a valgus force. And you can see that there's actually no true valgus opening. That only occurred if they additionally detached the anterior band, here marked in blue. And when both were completely detached, then you have a gross valgus instability as shown here with the red line. So the picture like on the left top side, you only obtain if you lose everything, complete lateral ligamentous complex lesion, and the flexor tendons as well. And but what you also can derive from this data is that you can also safely cut the posterior bundle of the UCL. So for example, in a stiff elbow, sometimes to gain flexion, you have to cut the posterior bundle, which is the floor of the cubital tunnel, and then you would not later create a valgus instability. How can you have a lesion of the medial ligamentous complex, again in a traumatic event? If you fall in your outstretched, pronated hand, then you first have a detachment of the ulnar collateral ligament, that can even propagate into a complete elbow dislocation. But it can also occur in throwers because they have extreme valgus force, particularly in the late phase of cocking, and then sometimes they feel a sudden pop in their elbow, and that indicates a lesion to the UCL. So in the last 2 minutes of my talk, I would like now to focus on the secondary stabilizers, which are again composed of the flexor and extensor tendons and the radiocapitular articulation. So due to the interest of time, I would like now to focus more on the radial head. The radial head is believed to be a very important valgus stabilizer, so the valgus load can be compensated by the radiocapitular articulation. And then the question arose, can we resect the radial head without losing much valgus stability? And that was done here in this study by Dr. Mori. And what you can see is an isolated radial head excision did not lead to a significant increase of valgus stability. However, when you first lose your ulnar collateral ligament, so the UCL, when you detach it, like here, so first release of the posterior UCL, not much increase of valgus instability, then they released the anterior bundle as well, then they had a more and more valgus opening, and if you then resect the radial head, then you have gross valgus instability. So that means you can safely resect the radial head, sometimes you do have to do that in comminuted fractures or so, if you have still intact ulnar collateral ligament. But it can lead to really catastrophic valgus and joint instability if you have a concomitant lesion to the UCL. And that can be very tricky in your daily life. Sometimes radial head fractures can have an associated ligamentous lesion, which is not obvious always at the beginning. So be careful if you do it. Always look at the ligaments. Just to sum up, some take-home messages. So the ulnar-humeral joint, the LUCL, and probably the entire lateral ligamentous complex, and the anterior UCL are the primary stabilizers of the elbow. Loss of 50% of the coronate and the olecranon can still be tolerated. The radial head and the common flexor and tendons, extensor tendons are secondary stabilizers. And be aware, do not resect the radial head when you have a concomitant complete UCL tear. This would lead to gross valgus instability. So I thank you very much for your attention.